Welcome, everyone. My name is Larissa DeLuna with the American Heart Association, and we'll go ahead and get started with today's webinar. Welcome to the second offering of the American Heart Association Stroke Webinar Series. These educational webinars are being brought to you by the Southwest Affiliate Stroke Committee. For a full list of the upcoming webinars, visit heart.org/SWA Quality. Before we get started, we'd like to go over a few housekeeping items. To avoid background noise, all lines have been placed on mute. For questions, you can unmute your line by entering *6 or type in the Q&A section of WebEx. Although this event is not accredited for CME or CE credits, attendees will receive a certificate of participation as proof of attendance. All slides, handouts, and participation certificates will be sent to attendees within 1 week of today's call. Also, please remember to visit heart.org/SWA Quality to view a recording of today's webinar. Now we'll begin with today's webinar. There is a recommended process to help make sure stroke patients receive all the right care. We're happy to have two guest speakers with us today to share this process, Dr. Margaret Tremlett and David Rundy. Dr. Tremlett is a stroke neurologist and the medical director of Washington Regional Medical Center's Stroke Program in Fayetteville, Arkansas. She is also the chair of the American Heart Association Southwest Affiliate Stroke Committee. David is the section chief of stroke and STEMI with the Arkansas Department of Health and is a member of the Southwest Affiliate Stroke Committee. Their presentation is titled Brain Attack Coalition Recommendations for Acute Stroke Ready Hospitals. At this time, I'll turn it over to David.
Quiet, please. Wait a sec. I'll take one. Oh, yeah. All right. All good. Take care. Way to go. Nice. Bring it on. Gotcha. I'm here for you. Oh, no. Please, please, please. I'm waiting. Interesting. Not buying it. Not fair. That's it. This conversation is over. Oh, brother.
Body language can tell you all sorts of things.
I'm having a stroke. I'm having a stroke.
Know the sudden signs. Learn fast. F, face drooping. A, arm weakness. S, speech difficulty. T, time. Time to call 911 immediately. The sooner they get to the hospital, the sooner they'll get treatment. And that could make a remarkable difference in their recovery. Learn the body language, the sudden signs, and spot a stroke fast.
Let me ask you a question. Why should we care so much about stroke? We should care because of the color purple. We should care because of this map. The more purple, the more stroke death. You can see a lot of purple, a lot of mortality in the stroke belt, the southeastern portion of our country. Do you know anyone who's had a stroke? Stroke affects so many families. Here's a picture of my family, about 1980. And there's a picture of me, and next to my twin brother, who actually lives in Twinsburg, Ohio. But you can see here my beautiful grandmothers. They both died of stroke. And, you know, this is a personal fight for me, and I imagine it's personal for you as well. Did you know that stroke occurs every 40 seconds? About 800,000 people a year have a stroke. It's the 5th leading cause of death. Someone dies from stroke every 4 minutes. It's a leading cause of disability. Did you know the cost is about $34 billion when you look at the health care services, people missing work, the medication costs, so an astronomical toll in terms of blood and treasure. And don't we want to do everything we possibly can do to turn the tide of stroke? They say that if you don't make waves, the tide will never change. Over the next 60 minutes, we're going to give you some tools you can pick up to help make some waves. We'll talk about the Brain Attack Coalition's recommendations. We'll talk about data collection and quality improvement. We'll talk about some resources, very important resources you may not know are available. And before we wrap up, we'll have some time to answer as many questions as we can. Let's start by talking about a group that's trying to make some waves. They try to make waves through sharing best practices. and they've researched a tremendous volume of literature, and their focus is on preventing stroke and combating stroke. The Brain Attack Coalition. You can see here the 16 groups that are in the coalition, including the American Stroke Association, part of American Heart, National Stroke Association, the CDC, and they looked over 12 years of data, and they came up with some recommendations. We're going to talk about these. They came up with some compelling points. They looked at the United States, and they report that over half of the country is outside of 60 minutes of a primary stroke center. And they said, we have to do something. We've got to have a better system of care because so many people are in these rural areas, and they're not within distance of going to a comprehensive or primary stroke center, so there should be a new level of care. There should be a standard of care for hospitals that can provide basic diagnosis and treatment, and we should call them acute stroke ready. And these are where the EMS should bring the patient and bypass hospitals that do not meet these standards. We're going to talk about these 12 elements of care, kind of like 12 pieces of a puzzle. And as we go through each of these, I'm going to kind of hit the academic, what the Brain Attack Coalition says in terms of specs. And then Dr. Tremlett will kind of take us down to the land of practicality and give you a specific tip, tool, recommendation, or story. But number one is something that's absolutely essential to organized stroke care, absolutely vital, and that is the acute stroke team. And if you look at their paper, came out a few years ago, Brain Attack Coalition says this team, having it in place, is an independent predictor of giving TPA. The team should have a physician and a nurse. Nurse could also be a nurse practitioner or PA. It's very important to have continuing education, at least 4 hours of education on acute stroke diagnosis and treatment every year. The team should be available 24/7. The team should respond within 15 minutes, can be on-site, can be off-site, as long as they can be at bedside within 15 minutes of being called. Now, Dr. Tremwell, how about you, would you like to share a tip or recommendation on acute stroke team?
When we first developed a stroke team here in Arkansas, this would be in Fort Smith, the most important thing I found was that the champion had to be a true champion, someone that really was compassionate about treating stroke patients. Now, that can be a doctor or nurse, doesn't have to be a neurologist, but it has to be somebody that is willing to really take the lead and over again emphasize the need for development of team. Now, the team you see there is the one from UCLA, and that's a huge team, but it can start out with just 2 or 3 people that can develop the protocols, guidelines, order sets based on the recommendations from the American Heart Association. And there are samples of that on the internet, and actually everything that we've developed here in both Fort Smith and up in Washington Regional would be available to you to look at and modify as you see needed. And then with the education and then developing the 24/7 readiness of the ER staff is the second thing that comes, but the champion has got to be the first.
All right, thank you, Dr. Tremwell. So we've talked about acute stroke teams. Let's move on to the second element of care, which is something very important to ensuring patients get all the right care. And that is having written stroke protocols. We know the importance of having standardized order sets, checks for vital signs, blood work, brain imaging. The protocols need to be reviewed annually and looked at against the latest evidence-based guidelines and updated as needed. They should include all types of stroke, hemorrhagic, ischemic. The Brain Attack Coalition says that while the written protocols, they can be on paper or electronic, they recommend electronic because it can be updated much easier, and plus it reduces chance of error. Dr. Tremor, what are your thoughts on stroke protocols?
Well, again, it ends up that if you can develop a protocol and order set that is very easy to use with just check boxes, this ends up being the easiest admission that a physician can do, because it would include everything that is needed to give the excellence in care for your patient. So it's everything from physical therapy and occupational therapy up to the what medications you're going to order, most typical medications, and then ordering the stroke neuro checks and those sorts of things. And it just makes it very easy to do that. And once again, if you're interested, you can just have our our order sets, and you can use them as you see fit. It also helps with your quality measures in that some of these things will be just ingrained in these order sets that they automatically happen, and so that you meet quality measures at 100% as soon as you institute these orders.
Yes, and we can get the folks on the call a copy of your protocols. Is that right, Dr. Tremlett?
Yes, at the end of this program, it has actually my email address, and that will be available. You know, just give me an email or however to contact us, and we'll get them out to you.
All right, that sounds great. So we've talked about the acute stroke team. We talked about written protocols. Let's go to something else. Now, this is an element that's actually outside the hospital, but absolutely vital to the stroke chain of survival, and that is EMS. We know the importance of EMS acting quickly, recognizing the stroke, communicating to the hospital, transporting the patient ASAP, the importance of EMS following a standardized stroke scale. It could be LA, it could be Cincinnati. In Arkansas, we're starting to use BFAST. The importance of EMS having training on stroke. The BAC recommends a minimum of 2 hours per year for EMTs and paramedics on stroke. The importance of pre-notification, because all the data shows that when the EMS pre-notify, call code stroke en route, that when the patient gets to the receiving hospital, there's a reduction in brain imaging time, reduction in door-to-needle time. So pre-notification is very important. And then the BAC talks about destination protocol, that ideally hospitals are bypassed that are not stroke-ready, but bring the patient to the closest stroke-ready hospital unless you have a higher-level care facility, a PSC or CSC, within 15 to 20 minutes. Now, we're going to ask you all a poll question. We've got some poll questions throughout this webinar. We'd like to hear from you. So, Larissa, could you please bring up the question on pre-hospital stroke scale?
There you go. The poll is open. You can answer it on the right-hand side panel of your WebEx.
Yeah, so I think we'll give folks maybe about 10 seconds or so. What scale does your local EMS use for pre-hospital stroke assessment, if they use one? Now, what is the poll showing, Larissa?
Let me close the poll so we can review the answers.
All right.
It looks like the majority used FAST.
All right. Majority use FAST. Now let's go on to another poll question. Larissa, the question about pre-notification. Let's bring that one up.
There you go.
So let us know, y'all, does your local EMS pre-notify the ER of incoming stroke patients? Yes or no?
And about 61% say yes.
All right. Now let's move ahead. Dr. Tremlett, what is your tip or what are your thoughts on EMS?
Well, as far as starting the program goes, they're probably the most critical part, because if they, in order for you to be able to give the thrombolytic therapies, the patient has to get to your facility in enough time. So what we started to do is our first level of education was ER staff, to give them the tools that they need so they could effectively and safely give the thrombolytic therapy. And then at the same time, we went out to the various EMS companies and did education on whatever tool you have, and I recommend that you all use the same tool. Then the way that the EMS communicates with the ER will always be consistent, so the ER knows pretty much what's coming in, and they can ready themselves, the CT scanner, and get a nurse to draw the labs as soon as the patient arrives. So I think the education of EMS is critical, and we went out to their stations. We didn't expect them to come to us. We went to them numerous times with just a canned talk we gave. It was a 30-minute talk, always brought cookies with us, and that was very effective. It also helps build relationships with the EMS. And then feedback to the EMS also. What happened to their patient, especially if they got a thrombolytic therapy, and I always call it life-saving thrombolytic therapy. And that just is such a sign of gratitude to them for the work that they did, that they recognize that they actually saved a life. So keeping them with the education and with the gratification knowing of the results of their work is critical.
Well, that's a great point, Dr. Tremlett, and I think everyone on this call agrees that bringing cookies is pretty powerful.
Yes, absolutely.
But I think you're right, and about everyone on the same page using the same tool. I think that makes a lot of sense. Well, let's move on. We talked about EMS, and let's talk about something else. It's very important to do this particular care element to ensure efficient patient care, doing it well, and that is having a well-organized emergency department. Making sure the ED has protocols in place for diagnosing, stabilizing, monitoring, and treating stroke patients. Making sure there's a standardized stroke scale. Everyone's on the same page, as Dr. Tremlett said. It could be the NIH stroke scale, a very well-known scale. Now, for EDs that don't see a lot of stroke patients, the Brain Health Coalition particularly recommends mock stroke codes, doing those codes to make sure that hospitals that don't see a lot of patients are still ready, the staff is prepared to diagnose and treat stroke. Also, the importance of education. The ED staff should have at least 4 hours, which actually is half the hours that they recommend for the Joint Commission for Primary Stroke Centers. But the BAC believes 4 hours is reasonable for ED staff for stroke education. And Dr. Tremlett, what is your thought or recommendation for emergency department?
Well, how we made that more fun, and actually it ended up being fun. It was people were a little nervous in the beginning, but made it a bit of a competition, and that one of the recommendations is that the ED physician has to see the patient within 10 minutes. Well, we time them, and each doctor gets their own result, plus the entire ER gets their result. And so one doc might be 100% within 10 minutes, and somebody is slacking off a little bit, then the teasing goes back and forth, and everybody is less than 10 minutes before you know it. And then the other thing is to really make sure that the ER understands that they are the center. They're the authority for treating of stroke. Granted, stroke's going to occur on the floors, but the center of activity and the expert people are in the emergency room. And again, that buy-in that they get really helps them develop protocols and really adhere to the protocols to really provide the expert care of their patients.
And it's an important, Dr. Tremlett, so they will help develop the protocols, involve them in the process.
Oh, absolutely. They were included in it. They made, I did a baseline, what I thought would be a protocol, and then they modified it, and we had discussion. And then also, it's a work in progress. Sometimes things have to change a little bit as we went through. Like, we didn't initially start out giving TPA in the CT scanner, but it evolved into that in order to keep our times as low as possible. And so with their input in it, that they actually made decisions of how they would change their practice to improve the care of stroke patients.
Well, that makes sense. I like Craig Valentine. He has this great quote. It says, people buy into what they help create.
Absolutely.
I think that's key to this process. That's a great tip. All right, so we've talked about a number of elements so far. We've talked about acute stroke teams and written protocols. We talked about pre-hospital. We just talked about the ED. Now let's talk about something else. And this next element is very important to make sure that the stroke patient can be treated with the right acute medication, and that is laboratory testing. We know that labs can help determine the cause of the stroke. We want to make sure these basic labs are done that you can see on the screen. The BAC recommends these tests be completed within 45 minutes of being ordered. Now let's do a poll question. Larissa, could you bring up the INR question? Okay, I think it's coming up. And if you all can answer, does your ER have point-of-care testing for INR, yes or no? I guess we'll give folks about 30 seconds, Larissa, or so. How's it look, Larissa?
About 38% say yes.
Okay, 38% yes. Thank you. Let's move ahead. And Dr. Tremlett, do you have any thoughts on lab testing?
Well, the recommendations have changed somewhat over time, that the one lab test that has to be completed before we give TPA is the blood glucose, and that could be a finger stick. Now, if someone is taking Coumadin, though, we have to have an INR to do that. So we use the point-of-care testing to do that, but it's not necessary. But again, you need some way of letting the laboratory know that this is a hyperacute stroke patient. So they are part of our stroke team. So they're notified when a code stroke comes to the ER, and the blood that goes to the lab is labeled code stroke, which means you can run a single, if you're doing batch studies, you can run one test as a batch. They don't wait to gather up enough to make it an entire batch. They run it on the sample that they have available right there, and that will help reduce time.
All right, that makes sense. All right, well, let's move on. Element number 6, we're halfway through almost. And this is something I think you're going to agree is absolutely critical. We got to do this. Critical for diagnosing the stroke. Brain imaging. We want to make sure we exclude other conditions that look like stroke, that are similar in symptoms, but we want to take out the mimics. We want to have the CT done within 45 minutes with interpretation from an appropriate physician. And the interpretation can be done from a different facility as the acute stroke ready, as long as there's teleradiology capability. And it needs to be certainly available 24/7 at the stroke ready hospital. Let's do another poll question. Larissa, if you could bring up the CT question. And if you all can answer, please, does your ER have CT in your ER? Yes or no? Okay, I can see the answers now. It looks like 38% yes, 39 or 29% no, 33% no answers. It's sort of a third and a third and a third. Dr. Tremlett, any recommendations on brain imaging?
Well, it needs to, you have to have a CT scan, and that's an absolute. And the biggest things that you want to rule out is there any blood? And even with suspicion of there being blood, you don't want to give the thrombolytic therapy. The person who reads it could be an ER physician who is appropriately trained, and I think the ER docs coming out now certainly are. Or it can be a teleradiology. Now, again, we use teleradiology at night, and again, these are called code stroke. And so that means they go to the front of their pile to read, and they know to read immediately and call us back. And they actually, we time, we use VRAD, virtual radiology, we time them and give them their data back to tell them what our expectations are of them and what their results are. And then administration actually uses that when they're negotiating contracts and things like that.
And isn't there some kind of like a repository of all the CT scans, Dr. Tremlett, that you all can access remotely?
Yes. Now, this is in the state of Arkansas. We have a telemedicine program, and what the hospitals will do there, the acute stroke ready hospitals will place it into the UAMS repository, and then the telestroke consultants can access it from there, so that I get to see CT scans across the state as quickly as they're done. But that's something you can get from a Telestroke program, which is an excellent way of addressing rural stroke care.
Yes, and we're going to be talking about Telestroke. In fact, I think, Larissa, there's a webinar coming up, I think in May, yes, I believe, where Renee Joyner, director of the Arkansas SAVES program, will be talking. So I think you all will enjoy that presentation. But thank you, Dr. Tremwell. Let's go on to the next element, which is something that's really important if your hospital is seeing a lot of patients that you're admitting to the facility, and that is a stroke unit. which all the data shows, if you look at the studies, reduces patient complications, improve patient outcomes. You can see here the basic components of the stroke unit. Now, the BAC does say that if your hospital is transferring out a lot of patients, not admitting most of your patients, that the need for having a stroke unit at your facility is really reduced. Dr. Tremlett, do you have any comments on stroke unit?
Yes. When we first started to develop our stroke program, the stroke unit was what I would call virtual beds. What's more important than having a specific physical location, it's having nursing that is trained in the care of a stroke patient. And so what we had were, on one particular unit, we had designated X number of beds that would be dedicated to our stroke patients, and there would always be a nurse or nurses on staff able to treat individuals in those particular beds, so that they knew all the protocols, guidelines, the order sets, they knew the nursing care for a stroke patient, were quite knowledgeable in determining if, doing an exam to determine if a patient was having worsening symptoms and then what to do with that. And so that really improved our outcomes tremendously with nurses with that advanced training. Now, that advanced training can be gotten in a variety of ways that are very feasible even for a rural hospital. A hospital as small as Sequoia Memorial Hospital in Oklahoma, which is about a 20-bed hospital, was able to provide that type of service. It was a virtual bed, wasn't a specific floor, but it was specific nurses that would take care of those patients.
All right, that makes a lot of sense. And I don't know in Arkansas if a lot of the hospitals have stroke units. I doubt that they do.
No, I think virtual units are more what we have.
Yes, and the BAC does make that point. So let's move on to element number 8, and we're getting now into the treatment, because we have a weapon in our fight. We have a few weapons, but one of the weapons can actually reverse a stroke, and that is TPA. We all know time is brain, time is of the essence with stroke. We know that TPA only works a few hours after the onset, so there's a very tight time window. The BAC talks about the importance of stroke-ready hospitals having 24/7 availability to administer TPA, and about how the door-to-needle time needs to be within 60 minutes, which is the same guideline for primary stroke centers. Let's do another poll question. Larissa, if you could please bring up, okay, I see here the question, which is, yes or no, does your hospital give IV TPA to stroke patients? How does that look, Larissa?
About 63% say yes.
All right, 63% yes. Now let's move ahead. Dr. Tremlett, I imagine you might have a suggestion maybe to help reduce door-to-needle or anything in general, any tip about TPA?
Yes, it's important that everybody be educated. Because it's a drug that is potential high risk, such as insulin, it falls in that same category. You have to have special education in order to be able to administer the drug even after the doctor's order, so that would require nursing training. We keep a bottle of TPA with even a spare in the Pyxis in the ER, and then there also is a bottle in the intensive care unit, because if someone on the floor is going to have a stroke, we always take them straight down to the ICU to deliver the TPA. And that's where the nurses are that are able to set up the drips and to bring up the bolus and that sort of thing. But the other thing is if your hospital is reluctant to put it on their formulary, to talk to your statewide Genentech representative. There are some issues that if the TPA expires, they just replace it with a new bottle without charge. And if, let's say, we had a patient the other week where we drew up the TPA, got the bolus ready, and then miraculously her symptoms resolved, didn't need to get it. Well, what they do in that case is you have to fill out a little form, but then they bring you another bottle and they replace the bottle that you never used on the patient. They replace it back in your hospital pharmacy. So only the TPA that you actually deliver to the patient is there a charge for, and of course that is reimbursed by insurance.
Well, that's a great tip because a TPA is pretty expensive, as I recall.
It certainly is.
So that's a great suggestion, Dr. Tremlett. Thank you, and that could save time, and we know time is everything. So we talked about TPA. Now let's talk about the next care element, which is something that may not be easily available, but it's something that many patients will need, and that is neurosurgical. And the Brain Attack Coalition talks about in their white paper to make sure that these services are available within 3 hours. And that could be whether the patient is going to another hospital that has a surgeon or bringing the surgeon to the stroke-ready hospital. But the total time has to be within 3 hours to meet the guideline. There should be a neurosurgical call schedule in place that's written. There should be a triage and transport plan. There should be a written agreement between the stroke-ready hospital and at least one hospital that has the ability to provide neurosurgical coverage on a 24/7 basis. Dr. Tremlett, do you have any suggestions on neurosurgical?
Yes, we have always used as our backup hospital the University Hospital. So for us, it would be University of Arkansas Medical Sciences Hospital. And I think every state has a program, a university hospital available, or the major hospital in, say, the capital or the largest city, and then to use that as your transfer hospital. And when it's 3 hours, that would be by helicopter, and that's from acceptance to getting the patient there. So, you know, and then in developing a protocol for transfer, that hospital would be well aware that you've set up a program for a stroke-ready hospital, and you've had some certification for that, and you're measuring your outcomes. So that makes that transfer even more feasible because they know that the treatment that you've given is the highest level of care that could possibly be given to the patient, but now in need for neurosurgery coverage. Now, the only time you really would need neurosurgery is if there is a hemorrhagic transformation of significance. Now, usually that is quite rare to occur. I think in the United States it's about 3% or 3 out of every 100. At our hospital, it's actually less than 1%. And I think if we were to continuously poll, like recent, that it's getting to be less and less as our ability to get patients into the ER improves and our knowledge about TPA and how to deliver it improves.
Yes, that absolutely makes sense. So we've talked about neurosurgical. Let's move ahead, and we combine elements 10 and 11, which is all about using technology to bring the big city care to the small rural areas, and that is telemedicine that you heard Dr. Tremlett address earlier. And Dr. Tremlett, you'll be able to address this a little bit more here. But it's all about increasing the appropriate use of TPA. And the data shows, if you look at the studies, that it does work. And the Brain Attack Coalition had 2 specific recommendations for telemedicine. Number 1, that the equipment be located on-site at the stroke-ready hospital to actually transmit the images. And then number 2, that the audio and video link needs to be put in place within 20 minutes of when it's needed. And let's do another poll question. Let's do a poll question. Larissa is going to bring up a telemedicine question, which is, does your hospital use telemedicine to evaluate and treat stroke patients? Yes or no? All right, how does that look, Larissa?
About 47% say yes and 26% say no.
All right. I guess the rest, they didn't answer. That
Correct.
gives us a sense. Now, Dr. Tremlett, what else would you add on to telemedicine? I mean, you're involved. Dr. Tremlett is one of our neurologists on call in the state for the Arkansas SAFES program. Anything else, any best practices or how to get started, Dr. Tremlett, any thoughts on telemedicine?
Well, there's a variety of ways of doing it. It can be small networks with a regional hospital, or a hospital system can do it, such as the Mercy system has their own Telestroke network. What we use primarily in Arkansas is, again, through the University of Arkansas in School of Medical Sciences in Little Rock. And then when you have something like that, you can actually have more backing to get larger grants that will provide the equipment, and then another grant that would provide the consultant support for that. And what's nice about this is that, and this will be in the May webinar, where a program such as that, if you can actually get a larger group together and then include education through that, then you really can give a lot of support to the rural hospitals as far as growth in education as well as supplies, and then they're actually able to extend it to outpatient education through these telemedicine grants. Telemedicine has been demonstrated to be as good as on-site delivery of TPA, and because it's delivered to institutions that wouldn't normally have this available to them, they're seeing actual improvement in outcomes throughout the state because of telemedicine. So using data, pilot data from other states can really be helpful in you if you're interested in developing a statewide telemedicine program to get that done. And also, you know, we talked about the radiology repository that's there for viewing the images. That would take, you wouldn't need to have another source looking at your images. It would be the consultant that provides the TPA to your patient and evaluates your patient would be there, plus standardization of the exams, the protocols, guidelines, order sets across the state gives a tremendous amount of comfort to physicians and healthcare institutions that the standard of care is so set in these protocols, guidelines, and order sets that if we follow them, then there's no argument about whether the best medical practice was done on your patients. The answer would be yes.
Well, absolutely. I mean, it's all about evidence-based practice. We want to increase the chances people will receive good outcomes having strokes. And we are very lucky. Dr. Tremlett talked about the Mercy Telestroke. We have 2 Telestroke systems, AR Saves and Mercy. And these programs are really making a big difference in our state. So I commend Dr. Tremlett for her work with the telemedicine program. Now, moving on to the last of the 12, we've gotten all the way through. The 12th element is very important to making sure patients receive all the right care, and that is patient transfers. Because we know that a lot of these patients, the so-called drip and shift, they'll be treated, they'll be stabilized, but then they need to go to a higher level facility for more definitive care, ongoing care, primary stroke or comprehensive stroke centers. The Brain Attack Coalition says the transfer needs to occur within 2 hours of arrival at the stroke-ready hospital. There should be a written transfer agreement between the stroke-ready hospital and the higher-level facility. It should specify that transfer can occur 24/7, and there should also be a written agreement between the stroke-ready hospital and the transport vendor that should give options both for air and ground transportation. I think this is our last poll question. Larissa, if you could bring this up. The question, you all can see it. Does your hospital have transfer protocol in place for stroke patients? Yes or no? All right, Larissa, how does that look?
About 53% say yes, 7% say no, and about 40% didn't answer.
All right, thank you. Now, Dr. Tremlett, do you have any thoughts or tips for patient transfer?
Well, again, I would use the same ideas for the neurosurgery coverage. An academic center would be always the default. It doesn't mean that you always use them if there's another hospital that's closer, but oftentimes the university hospitals, the teaching hospitals are interested in getting these patients. The other thing is if you have a Telestroke program where the generated from your state, it's not one that you actually purchase, but one that's within your state, like from the academic center, then they have a vested interest in your patients. And so that transfer protocol is quite easy to get in that case.
Yes, excellent. Well, that makes sense. And now that we've talked about the 12 elements, let's look at the 12 elements just in summary. And you can see here, you can see some apples to apples and some apples to oranges when you look at the 12 elements comparing the primary stroke centers with the acute stroke ready hospitals. There's some similarities. In fact, there's a lot of similarities, more than I suspected, but there are some differences. Just for example, they both require stroke ready and primary stroke centers that acute stroke teams have a 15-minute response time. They both require that stroke protocols are looked at annually and revised based on the latest guidelines. They both require door to needle within 60 minutes. There are some other similarities. Some of the differences, primary stroke centers require double the amount of education on stroke for the ED staff, and PSCs require faster turnaround on neurosurgical, 2 hours compared to 3 hours. But you can see there's a lot of similarities between the two. One big difference, though, is the compliance standard, that primary stroke centers are expected to comply with these elements at 80% or higher, meeting the measures at 80% or higher percent of the time that they do these care elements. However, the Brain Attack Coalition makes the point that due to the relative challenges, lack of resources, financial, staffing, that stroke-ready hospitals have a lower bar at 67% or higher. So that's a significant difference. Now that we've talked about the 12 elements, let's move ahead and talk about something else so that we know how well are we doing with complying with these standards. How can we track and improve care? And that's where data collection and quality improvement come to play. Now, treatment times are particularly important to track. There's certainly some differences in the elements that primary stroke centers will track because they'll look at the discharge measures, which may not apply because a lot of times the patients, of course, are transferred out in the stroke-ready, but certainly stroke-ready hospitals need to look at times. Very important. Door to imaging, door to physician assessment, door to telemedicine. You can see these times, door to needle. And having the ability to have a registry, we found in Arkansas is very helpful. We have a patient registry, get with the guidelines, to allow hospitals and to allow the health department to answer the two key questions when it comes to QI. Number one, what's working well? And number two, what can we do differently next time? Sort of looking for gaps and closing any gaps that exist. Now here you can see a chart. I thought you'd find this of interest. But this shows in Arkansas our data in aggregate for hospitals participating in the registry over the last few years, looking at one particular measure, defect-free care. And so we found that by looking at the data, working with the hospitals, and a lot of times the hospitals know when we meet with them what the challenges are, but just it's helpful for us to share some best practices with them when we find some gaps, but also to reward them, and we give them awards. In fact, we're about to give out an award for defect-free care coming up for hospitals meeting at it at, I think, 85% or higher. But we want to catch people doing things right, but also when there's some gaps, we want to share best practices. And Dr. Tremlett, I think you have a really good story. Maybe share that, Dr. Tremlett, your thoughts about QI and sort of how you found it helpful with the hospitals you've been working with.
I think that this is central to success in this program. I've done this now in 2 hospitals in the state of Arkansas, and we go through the same kind of a process each time. In the beginning, I collected the data, and at Sparks, actually, in the beginning, they didn't even want me to collect the data, but I collected it anyway. And then I met with data that is pertinent to practitioners. So doctors got doctor data, nurses got nursing data. And in the beginning, this happened to me twice, in the beginning, I was told that I didn't know how to collect the data. So then I went and got somebody to do secondary verification of my data and came back with that it was verified and it is true. And then there's got to be some other extraneous reason why it's wrong, and then I keep on bringing the data back to them and back to them, and then finally there is a realization that if they change their practice, that all of a sudden that the data will change, and that's usually by coming forth with the order sets over and over and over again and just tell them, if you just check this little box, it's done. Or if you just, for nursing, you fill out a certain thing in your care plan, you've got it done, and then all of a sudden they do that, and then they see their numbers going up. That's when the competition starts, and I've heard one doctor tell another doctor, you scored 80%, I got 95%, what's wrong with you? And so then, nobody's going to stand for that because we all got A's. And so then the competition begins, and the next thing you know, we're all performing at 100%, and that's the time for the big party then. And so I think that's really the big thing is you've got to look at your data. You have to allow some time for your practitioners to be in denial. And then when they come out of denial, have ready for them an order set or some sort of guideline, something that can help them be successful fast. And then accolades when they're successful, lots of accolades.
Well, I think that's a good point. That's interesting. You don't know how to collect that data. It's good. But I guess when you think about it, it's sort of like the psychology, right? It's like the principles of acceptance. You start off with shock and then anger and then, sadness, then acceptance, I think.
Absolutely.
But that's a great story, and I think it all comes down to if you do what you've always done, you'll get what you've always gotten. But to know how you're doing, you've got to look at the data. As they say, you can't improve what you can't measure.
Right.
In fact, we've got about 15 minutes left. Now let's go ahead. We talked about the 12 elements. We talked about the QI piece, looking at data to improve the data. Let's move on to some resources. I don't know if you all know about what resources the American Heart provides, but did you know that they have a stroke resource center online? Did you know that these materials, really good materials on stroke prevention, treatment, recovery, you can just download them and print them. Download, print, and share. They're in Spanish, they're in English, just phenomenal resource. And all you have to do is go to this website, strokeassociation.org, and you can see for yourself how valuable these resources are. Also, I don't know if you've seen this, I have this on my phone, my iPhone, this Spot a Stroke Fast. It's really good. I think we need to make a push to really get this all around our state and probably around the country. But it's just so good. It's all about recognizing the signs to act in time. And that's a big challenge we see, and I know it's around the country, that people are not recognizing, they're not calling 911 in time. We know all the data shows that when patients come in through 911, they have a better chance of having a better outcome. But I think this is a great app. You can find it on that website. I recommend downloading it, accessing, and sharing it. So American Heart has some great resources for you. Also, National Stroke Association. We've been working with them in Arkansas for a few years. They have really good materials. They have this great wallet card we've been using. This is also very popular, this color-coded risk scorecard that people can look at and they can actually decide for themselves what risks they are for stroke, low risk, cautionary, or high risk. We've been sharing these across our state. Also, these Act Fast magnets are good. And one thing the Stroke Association told me, I thought you'd find this of interest, that if you all order any of their materials by the end of this month, I guess by Halloween, using this code, you get a discount. So just go to the stroke.org. These are just a few samples. They have all sorts of materials, but I thought you all would find this resource of interest. Another resource, this is a great tool. Have you seen the National Institutes of Health, their free online certification for the NIH stroke scale? You can see that I took a clip. I went into the training, and it's a phenomenal course, but it's all free. It's for physicians and nurses. Just go to this website, NIHstrokescale.org, and if you all are not using this, I recommend giving it a try. Now, this is another resource. In fact, Dr. Tremlett shared this with me a few days ago. And you can see the link here, and I think Dr. Tremlett mentioned you'll be receiving this presentation, so you can click on this and access it. But this is about a 7.5-minute video. You can see this patient. It's a mock video, but Dr. Tremlett's in the video, and it's sort of all the steps this patient is going through along her journey of receiving TPA. And it's just great. And I don't know, Dr. Tremlett, any comments on this video?
Well, the reason for this is to show that you can give TPA in the CT scanner room without clogging up the traffic. And in this one, well, this would be the perfect patient because, you know, it's a mock. But we were able to give the TPA in about 20 minutes, and that was allowing 15 minutes for the doctor to arrive, and myself, to give the TPA. And so it kind of just tells you if you think that it can't be done quickly, but I think if you kind of look at that and sort of use, again, a protocol, you can actually deliver TPA well within 45 minutes without difficulty.
Well, it's a great video, and I recommend watching it, and I recommend sharing it. So we've talked about the elements of care, we've talked about QI, we've talked about some resources. Now, what questions do you have? And I think, Larissa, there may be some questions online. Any questions come up?
Just a reminder, everyone, you can come off mute with *6 to ask a question over the phone, or you can use the Q&A tab on the right side of your WebEx to ask a question via WebEx. We don't have anything in the queue right now. I'll go ahead and, as a reminder, everyone, you'll receive a copy of the slides and the resources and your participation certificates within 1 week of today's call, and today's call is being recorded. We will send a link to the recording when we send the resources.
Yeah.
Are there any questions? Again, *6 to come off mute.
And actually, I've got a question for folks on the phone. I don't know, I know we have a lot of smart people on this phone, but if you all have any other resources that you know about or any other best practices, we'd love to hear from you. Anything you'd like to share, let us know, or let us know afterward. All right, Dr. Tremlett, any other tips? I guess we have a few more minutes, but anything you think we should mention we haven't mentioned yet?
Well, I'd be interested to know if anybody is in the process of getting certification as a stroke-ready hospital or in their state are developing programs for statewide certification.
Yes, and in Arkansas, of course, we are. We now have 9 hospitals that are stroke designated. We call them Arkansas Stroke-Ready Hospitals. Our goal is to have every hospital that meets the standards to be part of this program. And I think one benefit, too, is that it demonstrates to the community that your hospital is able to meet a basic level of care and that you don't have to go out of your way, hour or so out of your way to the big cities. You can get treated, stabilized, and then transported later. But it's very important to go to the most appropriate hospital, and that's one of our goals in Arkansas. But I'd love to hear from other folks about if you all are looking at doing this sort of a program as well.
We did get one question in on the WebEx Q&A. Is there a minimum number of patients expected for acute stroke ready versus primary stroke center?
You know, I've read the white paper. I'm not familiar with that being addressed, so I would say I don't know. I don't believe so, but I'd be happy to check on that and get back to you.
And no, I don't think so. I think as long as you have mocks, the question is the number of patients that come to your ER?
Correct. I guess if there's a minimum patient requirement for either.
No, because it's actually meant to address that very issue, that it's even in a busy ER, it is not a frequent thing that you would deliver TPA. Sometimes it's just, you know, I think many busy ERs, it's once a week, that's a lot. And so that's why the mocks code strokes are so helpful.
Yeah, this is Richard Smith, Medical Director, Mercy Comprehensive Neuroscience Neurostroke Center in Oklahoma City. Can you hear me?
Yes.
Yeah, okay. We've made a couple of changes that are really easy to do for our hospital, one of which is when we're encoded, or actually when the patient comes to the ER, we page that over the overhead page. In the past, we've had so many phone calls necessary by our stroke team or the ED that it bogged things down. So that overhead page has made a huge difference. Everybody goes into action when that happens. In fact, we just had it a few minutes ago. And we also, of our 10 or 12 Mercy rural hospitals, we actually send a team out periodically to kind of educate them, kind of bring them up to speed on giving TPA and how to be organized, as well as they utilize our order sets and our Telestroke. But that does help to have a good relationship with your referring hospitals. And the third thing, we're actually moving to be fast instead of just fast. We were missing a few posterior circulation strokes, so we added the balance and eye symptoms on top of the fast, and that's helped a lot.
Well, I think that's great, and I like what you said, the overhead page, the education, and we're also looking at BFAST. In fact, in our Southwest region in Arkansas, that's the recommended pre-hospital scale. We want to sort of go region by region across the state, but we're starting with Southwest, but that's what we're using, BFAST, to collect more, so there's less strokes we're missing, but that's a great point. Thank you so much. Any other comments, questions?
I did have someone ask for some clarification about the Arkansas SAVES program. The CT does not need to be interpreted before calling the Arkansas SAVES program?
No, it does not.
Okay.
And that's the same way for Mercy's Telestroke. We just get the CT and we can see it. The stroke neurologist, whether they're at home or at the hospital, they can see it and make the determination right there.
Any other questions from the phone line? You can unmute with *6. Or type it into the Q&A tab of the WebEx.
Well, I can wrap this up, Larissa, if no more questions.
I think so. Let's go ahead and do that.
And I'll just say that we've all seen these stats. You all saw at the beginning of this presentation. And we have a huge tide of stroke in our country. But I believe that if we can follow these recommendations and we can have a system of care using stroke-ready hospitals where EMS can go to those facilities and bypass those sites that don't have the capabilities. And if we can do everything we can to improve the chances people get the right care, they'll get better outcomes, and use these QI principles that Dr. Tremlett talked about, collect the data, improve the data. And if we can use these resources, these tremendous resources from American Heart and from National Stroke Association, I believe we are going to turn the tide, and I think we are going to make some big waves in this fight. But we really appreciate you all joining this call. Thank you so much. You'll get a copy of this presentation. This will conclude the webinar. Thank you.
David and Dr. Tremwell, just want to tell you all thank you so much for taking the time to present for us today. It was very informative. We appreciate you.
You're welcome, and thank you.
Thank you, everyone. Have a good day.
Okay, bye-bye.
Bye.